This PowerPoint presentation highlights some of the lower extremity musculoskeletal evaluation tools that you can use, and my name is Dr. Resty, physical therapist. When evaluating an ankle injury, an acute ankle injury, it's very important to know the Ottawa Ankle rules. This will help you determine if an x-ray is needed. The first four have to do with palpation of bony tenderness, and this would be along the distal 6 centimeters of the posterior edge of the fibula, edge of tibia, the base of the fifth metatarsal, and the navicular bone. It's also important to note in the history, ask the patient if they were able to weight bear after the injury. This slide highlights on the left where you would palpate to find those bony tenderness areas. And on the right side of the slide, that would be the medial view on where you can palpate the bone. Please note in this PowerPoint presentation that we're going right into some of the specialty tests of the ankle. But with any kind of examination of a lower extremity injury, you'd also, after you've ruled your fracture out, you'd want to assess temperature of the limb, the pulses of the limb, the cutaneous sensation of the limb before you would begin any special testing. So here we are with the talar tilt. This is very standard for most examinations. So the talar tilt, we're going to be assessing the ATFL primarily and the CFL secondarily. The patient is seated with a foot and ankle supported in 10 to 20 degrees of plantar flexion. You stabilize the medial side, distal medial side of the ankle, grab the hind foot, and then provide an inversion stress. Trying to assess if you can feel the tilting in the talus. There's an awesome picture on the next slide for this. This slide shows the hand placement, and then on the right side of the slide you're going to see underfloral what this is looking like. That would be a very excessive unstable ankle. The next specialty test of the ankle is the anterior drawer. This will test the ATFL. The patient is seated with the knee and ankle in some flexion, and then you apply an anterior drawer force. We're looking for side-to-side differences, especially about 8 millimeters for a positive test. This slide demonstrates the supine position versus the seated position for the anterior drawer test. Part of your examination should include a manual muscle test. For plantar flexion, you want to test in standing, and on a single leg plantar flexion, they should be able to heel rise 20 times on each side. The other test, dorsiflexion, inversion, and eversion, you should not be able to break the plane. Hence, you should be stronger than they are. Now moving on to the knee. As with the ankle, the knee also has some rules to help us determine if an x-ray is needed, and these are the Ottawa knee rules. You can see it's age greater than 55, isolated tenderness of the patella, tenderness of the fibular head, unable to flex the knee to greater than 90 degrees or up to 90 degrees, and an inability to bear weight immediately after the injury and in the examination room. For straight plane instability of anterior instability of the knee, the Lockman's is a very nice test. It tests the integrity of the anterior cruciate ligament, or the ACL. The knee is placed in 20 degrees of flexion. You stabilize the distal femur, and you anteriorly translate the proximal tibia. I have a tendency to put my knee, hook my knee under the distal part of the femur, which helps provide me more stability, so it's easier on my hands. This slide shows how to test the posterior cruciate ligament, or the PCL. The demonstration on the left side of the slide is a posterior drawer. You can also do an anterior drawer, pull it forward for the ACL, and then posterior drawer is backward for the PCL. It is very important in the posterior and anterior drawer that you have a neutral starting position, because if you have a torn PCL, then it's going to perhaps give you more anterior translation if you don't know your starting point, and vice versa. The picture on the right, what you're looking at is you're looking to see if there's any sag where the tibia and the patella would be, so it's so that you don't see a drop off there. The valgus stress test, or medial stress test, is a test for damage to the medial collateral ligament, or MCL, of the knee. It involves placing the leg into extension with one hand as a pivot on the knee. With the other hand placed upon the foot, applying an abduction force, an attempt is then made to force the leg into valgus. If the knee is seen to open up on the medial side, this is indicative of medial collateral ligament damage and may also indicate capsular or cruciate ligament laxity. There are two versions to this test, valgus at 0 and valgus at 30 degrees. When performing the test at 30 degrees, the MCL is the primary stabilizer, but the joint capsule is also tested. When tested at 0 degrees, the MCL, the medial joint capsule, and the ACL and PCL are also stressed. Now moving on to the varus stress test. Here again, we will test both in 30 degrees and in 0 degrees of flexion. At 30 degrees of knee flexion, if the affected knee has increased movement compared with the opposite knee in a varus direction, the patient likely has an injury involving only the lateral collateral ligament. If the knee exhibits increased motion in full extension, the patient has an injury involving the entire posterior lateral corner, including but not limited to the lateral collateral ligament, popliteus tendon, and popliteofibular ligament. To perform the McMurray's test, the patient's knee is acutely and forcibly flexed. To check the medial meniscus, the examiner palpates the posterior medial joint line with one hand while grasping the foot with the other hand. Keeping the knee completely flexed, the leg is externally rotated as far as possible and the knee is slowly extended. To check the lateral meniscus, the examiner palpates the posterior lateral joint line and then internally rotates the leg as far as possible and then slowly extends the knee while listening and feeling for a click. The final slide in the presentation addresses iliotibial band issues, ITB issues, which is the most common cause of lateral knee pain. If there's no acute trauma to the knee, it's very important to assess the hip and the knee when a patient complains of lateral knee pain. It is quite common for our soldiers to present with lateral knee pain, and it is very important to assess their running shoes to make sure they're not run out or worn out. Also to assess their running patterns, whether they run on the same side of the road, down and back, or if they're on a track workout going the same way consistently. And also to look at some of their core strength to see if they need to strengthen their glutes. Treatment is going to be foam roll, stretch, ice, and address any of those hip issues that they might have. And also the biggest gift we can give to our patients is teach them how to prevent the injury from reoccurring. Teach the soldier how to train smart, increasing distances slowly, cross-training, and making sure to strengthen the glutes and the core. Thank you.